I think that's
Is it okay for me to start, Emmanuel?
Petra.
Okay. Perfect. Right, I'm going to start then. Hope you can all see my slides. Yes, no, anyone can let me know?
Yes, I can.
Okay, perfect. Thank you so much. All right, so welcome everybody, and thanks so much for joining me here today. And this is part of our webinar series for the AFEM Nurses Group. So my name is Petra Brysiewicz, and I'm a professor of nursing at the University of KwaZulu-Natal in South Africa. And I'm also a honorary professor at the University of Cape Town in the Emergency Medicine Division. So I've been asked to present today on why engaging with families in care is important in the emergency department. And so I'm looking forward to hearing your comments at the end, your suggestions, your questions. And as we go through, if you have something, please also feel free to write it in the chat, and then I'll have a look at it at the end. So as I'm sure I don't need to even say much about, families in the emergency department are very challenging. The emergency department itself is a difficult environment. It's a very fast-paced, busy, noisy. There's very little privacy. There's often not much space for people to be. There's very little places to sit down and to wait. So it really is difficult for families. The staff themselves are usually very, very busy, working within time constraints. So having to spend time to talk to families who perhaps are asking you multiple questions many times makes it extremely challenging. And you might well feel like this lady here who's trying to hide from them behind her hands. So when we are thinking about families and discussing families, one of the most important things, obviously, is to really be clear about who we are talking about when we say the family. So there's a number of ways that people define families, and I just want to take you through some of these because I think it's very important for us to really think about. So families have been defined as a group of individuals who are bound by these strong emotional ties and a sense of belonging, a passion for being involved in each other's lives. As I'm sure you can all agree with. Then with the families that we see in the emergency departments, they are also the people who feel the need to overcome sort of the challenges in attempting to care for their loved ones who now have this particular conditional ailment. And it's also been defined as a system bound by biological, legal, as well as sort of guardian and sociological aspects to it. So we did quite an interesting thing a number of years ago, is that we spoke to 232 undergraduate and postgraduate nursing students, and these were students from South Africa as well as from Sweden. And we asked them to define family and also then to describe who they considered to be their family members. It was quite an amusing exercise because some people had quite a strange way of writing down their family members and listing sort of them in levels of importance. And for some, we could see how perhaps the husband wasn't the most favorite person in that family because the student who was entering the information in listed her children, her parents, her everybody, her dog, her cat, her chicken, and then she listed her husband. So obviously things weren't too good in that household. But we asked them to put all this down for us, and we then used it to help sort of define who these students and what they understood by family. And we had these things listed below. So they saw family as being people that were tied to you through kinship, either through sort of legal connection or through perhaps your ancestors, that kind of lineage. There were ties of love, so people who you shared resources, you cared for, you trusted, you had these kind of special moments with when they're viewed as family. You also had ties of influence, people that you had a shared ideology with, you had a shared belief, you perhaps grew up with these people. We also had a definition of family in terms of having these everyday ties. And an example of this was the students who were perhaps living in residence, and they would say that the people that they are living with there, they're considered to be their family. They shared shelter, they shared day-to-day living experiences, and they considered them family members. And then there was also a category that we then termed tied by slip knots, because this sort of emphasized the idea that there's fluidity in who you consider to be your family member. And perhaps who you consider today as your family might not be the same people in a year's time. Sometimes it changes. Now you might sort of say, well, why is this all very, important and necessary for me to spend time on? Because it's really important to think about who the patient views as their family member. This is just a picture that I always like to show, how we can have our own ideas what family is, but sometimes that's a different perspective from the patient side. So this is a zookeeper who was receiving palliative care, and his sort of dying wish was to be visited again by his favorite, he said his favorite family member, who was the giraffe that he had spent many, many years looking after. So in order to really work towards engaging with families, involving families in care, the field of family nursing has developed. And the major assumption sort of leading family nursing is that health and illness concerns that is experienced by an individual truly has an impact on the entire family. And really in family nursing, what we always like to sort of come back to saying is that illness is a family affair. It's not something that stands alone with the patient. Their entire family is involved. And within the African kind of context, I think it's really important for us because community and family is seen as vitally important in our continent. And families often play a very active role in actually providing the care to our patients in Africa, just because we have issues around resources and having insufficient healthcare practitioners. Unfortunately, family nursing is not something that we understand as a speciality in Africa. We would all agree that we know that family is important, and when we have probably done our basic nursing training, we've always been told that we need to really consider the family and think about them, but I don't think we've really fleshed out what that means and given it much sort of thought further than that. So family nursing is the integration of family care, of nursing care to both the patient and the family as a whole. And it really also looks at the relationships between the patient and their family member. How is this kind of illness experience, and how is this illness experience affecting the family as a whole? And I'm just referenced here the International Family Nursing Association. I'll tell you a little bit about them a bit later, but they have a number of position statements and resources which are really interesting and useful to read if you're interested. And there's the web address. So why should we involve families in care? Families play an important role in caring for our loved one, while at the same time, assisting the healthcare professionals, because often the patient will arrive and we will want to know, what medication are they taking, what happened at home, what have they been eating? And it's usually the family members that are providing this kind of important information for us. And there's been a number of research studies that have been carried out that demonstrate that good sort of collaboration between the healthcare providers and the family leads to positive patient outcomes and improved satisfaction with the care that's received. So in terms of these positive outcomes, various work has shown that it assists with the families themselves can assist with the diagnostic tests and reducing adverse events, decrease length of hospital stay, and shorten the hospital stay overall, lead to improvement in health literacy, improved self-care in terms of chronic disease management, and improved clinical decision making and patient safety. So there are a lot of ways that we have shown through research that families are important in involving in care. So this is Dr. Janice Bell, and she's been very instrumental in developing family nursing throughout the world. And I just wanted to add this here to this presentation to say, what she sort of sums it up by saying that family nursing is more than family-centered care. She's saying we need institutional endorsement and support to systematically teach all healthcare providers how to address and soften illness suffering in individuals and families through brief therapeutic communications. So much of the research that has been done around healthcare providers interacting with families is really just around the fact that they want to be spoken to and they want to be talked to and to be talked to in a therapeutic way. So hence her quote here. So I just wanted to go through just a little of some of the research that I've done over the years, just to highlight some of these important points around involving families. So work done with nurses sort of detailing their thoughts and perspectives on families, dealing with families, managing families is what I've got here. So they were saying that families are subservient. They don't want to talk. They are afraid. They don't want to come forward. So this nurse was busy explaining how it's difficult then to engage with them sometimes. The literature also and the research also talks a lot around how our families in the emergency department are in crisis. And so they are difficult people to manage. They're very disruptive. They are unpredictable. Unfortunately, in the emergency departments, we often see families who are under the influence of all sorts of whether they're drugs, alcohol, etc. So they are difficult to manage. They are time consuming. And we know that the emergency department, we are busy working under time pressured environment already to manage the patient. And now you have to add more time on to talk to the family and interact with the family. And this is one of the things, and it might not be a problem in all countries, but it definitely can be a problem in my country, that sometimes the nurses are not aware what the doctors have actually told the family. So they don't know what they can and can't say. And sometimes if they say too much, then they get into trouble with the doctors. And if they say too little, then they get into trouble with the family members because they say, you are holding things from us, you're not telling us. So the nurse then starts feeling like they're stuck in the middle and they don't really know what they should do. And the safest thing seems to be just to stay away. So when we talk to family members around their sort of feelings, this is just from some of the work done with family members of critically ill patients, critically ill trauma patients. They were saying they often feel invisible when the staff are coming past them. They avert their eyes, they try and look down, they try not to make eye contact. So they're avoided and neglected by the healthcare professionals. And they say it actually makes them think that we are a bunch of very unfeeling, cold people. So this is just something from one of the families, which I think is really important for us to think about. The tiniest little thing that's done for you is so important. You'll never forget that nurse giving you that cup of coffee. It might seem absolutely insignificant, but it's just important. And this was actually something from a family member whose loved one actually died in the emergency department. And having that cup of coffee just made the difference. She just said if it wasn't for that cup of coffee, she's not sure she would have managed to survive through that day. So we also did some work looking at assessing families' needs. And we looked at families within the first 24 hours and we evaluated, we sort of asked them to tell us about their needs. And their highest sort of needs were really around assurance and information. So they wanted to be assured that the best care possible is being given to their loved one and that they know specific facts around the patient's progress. The lowest sort of rated needs were about to be alone at any time or to have a place to be alone. That was really the lowest rated kind of priority. But what was really important, and I've put this here to emphasize today, was that their needs actually increased over 72 hours, because we went back and we asked them again in 72 hours, and we were expecting to see that their needs had actually reduced, and hopefully that, you know, the things had sort of improved for them. But in fact, their needs increased over 72 hours. And it was really due to them now having new needs, you know, things changing, so their needs changed, but also that their sort of needs had remained unmet. So when we looked at our literature, we really saw that our needs here in that we had found in South Africa were really higher than other international studies. And probably the reasons were around the fact that, you know, we were looking at families of trauma patients, and we know that trauma is, you know, this unexpected, very emotional kind of situation. And so possibly those family members had higher needs and more complicated needs than families in other parts of the world. We know that the fact that we have resource constraints and challenges around that also makes difficulties for families. And in South Africa, and I know in a number of other African countries, the family members in the emergency departments and in the ICUs have very limited involvement in patient care. And often they're basically told to sit outside, or are told to, you know, come and sit at the bed and then go. So that sort of adds to these needs. So we had a look at asking families just recently about the sort of, it's relational practice. It's about having a meaningful relationship between individuals. So it was really around families interacting with healthcare providers in the emergency department. And this is what they had to say, that really for them, this is a disrupted world, this whole experience of having this loved one in the emergency department. It's out of the normal events. And for them, it's extremely bewildering, and something very important for us to think about when we're starting to obviously interact with them. That they were saying that care is what you see and hear as caring. So they want to feel secure. They want to feel that it looks like you care when you interact with them as a healthcare provider. And that has a lot to do with how you say things, how you look on your face, how you approach the family. They also mentioned, unfortunately, again, which has been a common thread definitely throughout all the research I've done over the years, is around being powerless, and them finding staff to be quite dismissive of them, and families also feeling disconnected. And I thought this was quite nice. They were saying that, you know, in terms of the families, they think that the healthcare providers just see them as a number. So when we're looking at things in Africa, I think we're often thinking about the fact that, you know, we have issues here because of the challenges that our continent has, and that things are better in other countries. I was involved in a study that was done across 10 different countries to really look at how nurses engage with families. And while this was engaging in the critical care environment, there are still so many similarities to what we've found in our work here in Africa. Sorry. And basically everybody across the world seems to be saying the same things. So here we found that family nurse engagement is this ebb and flow of relational power. So sometimes the nurse holds the power, sometimes maybe the patient's family has the power because we need information from them, but it's all about this to-ing and froing of power. There are constant fluctuations in the nurse's practice of engagement because it really does depend on different nurses and different shifts. How people engage with families is very individual, and it seems to be from the health provider's perspective, if they have had their own experience of having a loved one, perhaps in the emergency department, who's been critically ill, that really shapes the way in which they manage families in the future. So the family engagement is dependent on this individual nurse's attitudes and perceptions. And it's also shaped by the context of the ICU or the healthcare environment, because it depends on if there's any kind of team culture around interacting with the families. In some of the units where the doctors and the nurses and the physios and everybody is thinking a bit about the families, they're involved. And if they're not, then they are not. So sometimes, you know, when I talk to nurses and doctors and they say, well, they don't know what it is they're supposed to be saying. And so it's easier just to stay away. And so that's why I put this here, just to say that patients and their families often just want someone to listen to them. And sometimes even silence is the best answer. So one of the things we also looked at was sort of how to measure families' experience in the emergency department, because it would be quite a useful thing to be able to evaluate the care that you're giving to families and to see how you're doing as an emergency department. So we had a look to see if there are tools that actually measure families' experience or satisfaction in the emergency department. There are a number of tools that do measure patient satisfaction and experience, but we only managed to find 3 that measure the families. And one of them is actually the critical care family needs inventory, which is really usually used in the ICU, but someone's used it in the emergency department. And then somebody modified that for the emergency department. And there's one other tool. But really, these tools are around measuring sort of communication, comfort, and support. So they are there if you want to find them and have a look at them. So I want to just tell you a little bit about the International Family Nursing Association, which is an association, international association that really looks to transform family health. And to do this by sort of becoming this unifying voice for family nursing globally, to share practice, to encourage research, and to really try and promote the education of family nursing and teaching nurses how to really engage and collaborate with families. So we have just recently established the African chapter of the International Family Nursing Association. And we are hoping to introduce, promote, enhance, and sustain family-focused nursing in Africa by sort of doing these same things, but perhaps just within our continent. I've also listed here, we have a number of initiatives that we are going to be doing around education, practice, research, in order to try and ensure the sort of development of family nursing. And I think one of the things is we don't understand it as being family nursing, but once you start talking to people around engaging with families, then we're all doing that to some degree. Obviously, just to sort of get towards the end of the presentation today, just to mention families and COVID-19. Obviously, in the emergency department was a huge thing. Dealing with social isolation was one of the major things, having to, drop people off at the emergency department and walk out as family members was a huge issue and a huge challenge. We also had to find new ways to communicate effectively because everybody was fogged up in all their PPE, as well as being able to communicate then with families who were not allowed in the emergency department. And to say that, family nurses were extremely, you can just mute yourself, please. That is. Nurses became very innovative and came up with all sorts of interesting things thanks to COVID. So one of the ways was to try and promote communication when you were all togged up with all sorts of PPE. And this was done in many places where people put their pictures and their names, so people actually knew who they were being treated with. This was one of my favorite, where nurses in Brazil actually were very concerned about patients who were ventilated and alone because family members were not allowed, next to their bed. So they created the hand of God, which was a glove filled with water that they could then put on the patient's hand and allow them to feel as though, a family member or somebody was there holding their hand. I also just wanted to let you know that one of the things that we're also doing is collecting COVID-19 stories about nurses' experiences with families. So if you are interested in perhaps providing your story, this has details around what's needed. It's really just to write a little short description of how you were interacting with families, etc. So if anybody's interested, please do email me afterwards and I will perhaps tell you a bit more about it. So engaging families in care is not just better for the patients, but it really is crucial to the success of the healthcare landscape in general, and especially in the emergency department. It is very challenging and it is quite difficult to manage this process, but it can be done. And patients' families can become active partners in decision-making and care. Obviously, there's degrees of their involvement, but all of this sort of, in order to work towards this, it requires a change often in the mindset of health professionals. So just to end off, we obviously have spoken about how providing family-focused care is challenging. Addressing the needs in our particular environment with its time constraints, with its resource constraints, is very challenging, and a lot of our sort of cultural and our lack of health professionals adds further to these difficulties. Interventions that we can have for families and ways to involve them really can be very simple. can be very short, can be cost effective. And I would really encourage you to explore that. So I think especially in Africa, there's lots of work that still needs to be done in this area. So just thank you very much. Thank you for listening. I've put my email here in case anybody's interested in anything more to do with involving families in care or family nursing or the COVID-19 stories. Please feel free to drop me an email. So thank you very much. That's all that I have for today. I think we have a little bit of time for questions if there are any. If you would like to, if you want to ask a question, please just unmute yourself and ask it. I can't see any hands up, or if you want to make a comment, or if you want to disagree with what I was saying, you're also very welcome to.
Thank you very much, Petra, for the presentation. I think this is timely. It's about time we begin to recognize the importance of family and the care of patients. So I believe this message is well received. And if we have further questions, we'll be coming back to you. At this point in time, we're still waiting for individuals who have comments, questions to come in with this as well.
Yes, would you like to go ahead? David, well, I don't know how to pronounce it, sorry.
Hi, Zena, please go on with your question.
Is it Zena? Okay, sorry, please go ahead.
Hello, Professor Petra and everyone else. Thank you very much for this very interesting presentation. It's really given me a very different outlook on family nursing. So I just have a question. I wonder if you found maybe that the workload of nurses or the fact that there is always shortage of staff, does that contribute some way in nurses not being able to engage with families as much as they would have liked to?
No, definitely. That's one of, thank you very much for the question. And obviously that's one of the things that makes it very challenging for us, in Africa. But I think there's also the other idea that you have to spend a lot of time with families, and you don't have to. Families obviously want their loved one to be looked after. That if you have limited time, they would much rather you'd be spending it with their person that needs your help. So I think that yes, it does affect how much can be done with the families because of our staff constraints. But I think it's also that we have the idea in our head that we have to take a lot of time with families, which we don't. We can take a very short bit of time, but it's about acknowledging that they were there. So just being able to walk past and say, I see you, we're still busy with them. I'll let you know as soon as we know something, and walking straight past, is fine. It doesn't have to be a lengthy thing. And I think, for us in Africa, we rely a lot on families to do a lot of the work in a number of places because we don't have enough staff. So I think it's just working together with them. But there are a variety of ways, but a lot of the interventions or the ways that we have seen previously in the literature speaking about how to involve families always seem to be very costly, because I remember when I started reading the literature about 10 years ago or whenever, they were talking about how you needed a family liaison person, you needed another room where they could sit down, you needed to give them tea.
Exactly.
Exactly. And that is perhaps a model that the high resource countries can do. We can't do that.
Mm.
We don't, that's not what we need to be doing, but there are things that we can do in our low resource, which would be just as beneficial for the families, and our families wouldn't expect that, you know. They'd want us to be, we can't even feed our patients sometimes. We're not going to be making coffee for the families. So we just have to
Yes, absolutely.
do what we can with our resources.
Yes, I think you're right. I think it comes down to quantity versus quality. And if I could just throw in a personal experience, that there tends to be a perception that if you're very close to the family, or that you're updating them all the time, or that you're giving them the information, then there is something in it for you, and that you've probably been given something extra on side, or you're getting something out of it. And it's really strange, because sometimes you just feel like you need to update the family because they're really distressed or distraught. And so that's one. But also, I really, the point that really caught my attention was how we don't have sort of a communication with the doctors, and so the doctors update the family in a very different way, and you're not always sure what to say. And I know this because I've experienced it myself. Like, you end up saying something that you probably weren't supposed to, or the doctors didn't want you to tell them. So I think that's something where the doctors and nurses are on board, and you know how to update the family. I think that should be amazing. But yes, thank you very much, because this is really it's really opened a new dimension for me. I think family nursing is so interesting. Thank you very much.
Thank you. And you are covering very important points. And if in my talk I said what you need to do is you need to look at the culture of the environment. So you're absolutely right. You have to have the doctors and the nurses and whoever else works in that department together deciding that families are important, and you need to look at how to involve families or how to interact with them. Because if you just try and do it on your own, you're absolutely right. People get very suspicious. People wonder what's wrong with you. They think that maybe you don't have enough work to do, or there's something. But it needs to be a team approach. So in your unit, you need to all come together and say, okay, we need to look at this as a team and decide how we're going to manage it. But thank you. Those were all excellent points. Are there any other questions or comments? I don't see any. So hopefully that means that I have hopefully it means I've answered all your questions and given you lots of things to think about, and not that I have put you to sleep and you've just fallen asleep next to your computers. And unfortunately, I won't know which one it is. Emmanuel, what time are we due to finish?
We had 45 minutes for the presentation, including Q&A, and I think that we still have a bit of time for people who have questions and contributions as well.
Okay. Do we finish at 3 or 1:45? Do we finish?
No. I think so far we've done almost about 40 minutes. We may have about 5 minutes more for questions and answers if anybody has any.
Okay.
This webinar is recorded and we will be posting it on the AFEM website for individuals who want to look at it again, especially those of you who joined late.
And like I said, if you have any anything that you want to ask, or you would like some more information, please feel free to just reach out to me and send me an email, and I can link you up, because I think it really is something that we have to think about from quite a broad perspective. So thank you to all the comments in the chat. I'm glad to see that you were all still awake. And it's nice to see familiar faces. Yes, there's quite a few of you that I'm seeing from the past. So thank you. It's lovely to catch up with you again. There doesn't seem to be anything else. Should we be ending, Emmanuel?
I think we can call it a day.
You want me to end off?
I think we can end, Petra.
Okay. All right. So I'll just say thank you very much. Thank you for your attention. I know it's a Friday afternoon, but thank you for coming to listen, and thank you very much to Emmanuel for putting these webinars together. And remember, we're always looking for speakers. So if you're interested, I'm sure just reach out to Emmanuel. I see that there was one question here around privacy. How do we handle the issue of privacy? I'm not quite sure, were you meaning privacy in terms of talking to the families or?
Yes, my name is Lino. Thank you for that wonderful presentation. You'll find out in most EDs, especially around, the African continent, or maybe all third world countries. There's always the issue of the infrastructure, and then you'll find out there's only one waiting room for different family members for different patients. So in terms of updating family members, how do we tackle the issue of privacy in terms of what information do we give to them, and how do we deliver that information to ensure privacy and confidentiality?
That's a great question. And there's lots of stuff around having difficult conversations and how you can have them and where to have them. So I'd encourage you to have a look in the literature as well. But basically what I would say to you is that you do the best you can with what you have. So if you have an environment that allows you even just a little more secluded area where you just walk down the passage and you can have a little bit of a more quiet environment there, then that's where you have to go. If you are lucky enough to have another room where you can take family and talk to them, that's where you go. You know, we can say what the perfect thing would be, and that would be to have somebody there with them, to be able to refer them to social workers and psychologists, to have a family liaison with them, to have a separate room, to have a nice box of tissues and a cup of coffee. But we know that that's not the reality in our environment. And I think that as long as you are trying, and you are trying to provide the best that you can with what you have got, I think that your families would be appreciative. So that as long as you don't just stand at the foot of the bed and say, well, he's going to die, and you say it in a very uncaring way, loudly, like you don't really have any thoughts on the matter, you're not thinking about their feelings, then that's going to be a problem. But families really understand that we have to work within the constraints of where we are. So I think as long as you were trying the best that you could to be sensitive to their needs, to try and maintain confidentiality. And like we were saying earlier, be very careful what you say and whether you're allowed to be saying it and you have the right people in the team to provide that information, is the advice that I would give you. I hope that answers your question.
Yes, it does. Thank you very much. And you are right in that point that family members are really appreciative, especially if you actually show that you really care about the patient and that you actually acknowledge that the family members are there for the patient. I think, yeah, you're right. Like the little that you can do goes a long way, especially for families.
Yeah,
Thank
yeah. No, I agree with you. You're absolutely right. Yeah. And it is just about showing that you are a person acknowledging that they're having a terrible time and you're trying your best to help them. That's all. Yeah. I'm just checking in the chat if there's any other questions. Okay, I don't see anything else. All right, and I see nobody else's hands up. So thank you very much for the messages in the chat to thank me for the presentation. I'm very glad that you found it useful. Please feel free to reach out and go and enjoy the rest of your Friday. And hopefully some of you are having time off over the weekend. Take care and thank you so much. It was lovely to see you all. So thank you. Goodbye, everybody.
Thank you very much, Petra. Bye.
Bye.